Good evening, ladies and gentlemen. Welcome to Day 6 of the Asian Oncology Society Conference. To open today's session, please welcome Dr. Agnes Famero, Product, Services, Technology Manager of Ralmas Health Group and Functional Medicine Physician at Life Science Center for Health and Wellness BGC, Taguig, Philippines.
Good evening, ladies and gentlemen. The next lecture is entitled Technology of OncoGenomics, Application in the Clinical Setting. Our distinguished speaker is Dr. Frances Victoria Ke, a clinical faculty member of St. Luke's College of Medicine and medical oncology consultant at the following centers: St. Luke's Medical Center, Quezon City; St. Luke's Medical Center, Bonifacio Global City; St. Louis Hospital, Sultan Kudarat; Healthway Greenbelt; and Centuria Medical Makati, Philippines. She received a Certificate of Achievement from Cancer Genomics HMX online course by the Harvard University and had her observership training in cancer genomics at National University Cancer Institute in Singapore. Ladies and gentlemen, please welcome Dr. Frances Victoria Ke.
Good day, everyone. I would like to thank Global Medical Technologies for giving me the opportunity to speak at the Asian Oncology Society first virtual conference. Today, I will be discussing about personalized cancer genetic testing through RGCC. RGCC, or Research Genetics Cancer Center, is a specialist medical genetics company established in 2004 with headquarters in Switzerland and laboratory in Greece. They are experts in developing and providing personalized cancer genetics tests for doctors and patients, and testing tumors for sensitivity and resistance to chemotherapy. They are actively involved in pharmaceutical research and development, and their facilities are equipped with the most technologically advanced equipment and specialized software for data analysis. RGCC is a global organization working in collaboration with branch offices and distributors in 23 countries across the world to provide a worldwide service, and as such, they are ISO certified. The main goal of RGCC tests is to discover, analyze, and screen cancer cells in every step of the disease. RGCC tests are designed to achieve these aims: to detect potential early signs of undetected cancers, to monitor existing diagnosed cancers, and to produce personalized guidance on which chemotherapy drugs could benefit individual patients. From the three aims of RGCC, we can say that their main goal is to give a personalized treatment plan to cancer patients. Personalized medicine entails the stratification of patients to different therapeutic protocols based on biomarkers. An example would be RAS wild or mutated type selection of patients to be treated with anti-EGFR monoclonal antibodies for colorectal cancer, or EGFR mutation testing of patients to be treated with anti-EGFR tyrosine kinase inhibitors for metastatic lung adenocarcinoma. The following chart shows the range of available diagnostic tools from RGCC. And first, I want to focus on diagnostic tools which tell us about the efficacy of treatment agents for cancer. There are two tests available: OncoGenomics and Cambisec. First, let's talk about OncoGenomics, which detects circulating tumor cells. Circulating tumor cells, or CTCs, are cancer cells which have broken away from the primary tumor and have entered the bloodstream, where they circulate and have the potential to generate metastatic disease. This subset of cancer cells is often associated with the rise of metastatic sites and cancer-related morbidity. Researchers have made significant progress in protecting and isolating these cells, but CTCs are not yet 100% accurate. Detecting and sampling these cells is a form of liquid biopsy, which is a sensitive and minimally invasive method for early detection, disease monitoring, and identification of potential druggable targets. Many studies have shown that their number can be correlated with disease progression and poor prognosis in various carcinomas. We calculate the number of circulating tumor cells from the total amount of blood cells, expressed as the volume of circulating tumor cells per milliliter of blood. The average number of CTCs in a blood sample is 10 to 30 cells per 50,000 units of cells, where RBCs and platelets have been subtracted already from the count. That's 0.02 to 0.06%, which is such a small number. So how can we find the needle in a haystack? There are several methods for CTC detection, such as beads-based method, PCR-based method, flow cytometry, microscopy-based method, and gradient. Flow cytometry is a rapid, reproducible, and sensitive method for detecting antigens in cells, both intracellular and extracellular. It provides the opportunity for multiple antigen detection simultaneously, as well as DNA aneuploid populations. In flow cytometry, the method of isolation is flow cytometric sorting with interrogation in droplets in ratio of droplet per cell of 1:1. Purity of CTCs is higher than 97 to 99%. Viability is more than 99%, making the CTCs appropriate for further molecular analysis since there is no noise. Selection of CTCs is done based on negative and positive selection in order to identify and immunotype CTCs. This method allows performance of gene expression assays and determines features vital for therapy scheduling. A study by Papasoteriou et al. In 2015 found that in people with certain types of cancer of the breast, prostate, pancreas, colon, and skin, this test is 87% sensitive and 83% specific for circulating tumor cells. In a study by Guadagni et al., it was demonstrated that CTCs are both feasible and useful in predicting response to therapy. Viable metastatic epithelial ovarian cancer CTCs were enriched by transient culture and identified by RT-PCR and indirect immunofluorescence, were subjected to flow cytometry-based assays for chemosensitivity to several chemotherapeutic agents, and by RT-PCR for tumor gene expression profiling. Using a cutoff value of more than 80% cell death, CTC chemosensitivity tests were predictive of patient responses to therapy associated with 100% sensitivity, 50% specificity, 33% positive predictive, 100% negative predictive, and 60% accuracy values. The methodology employed in this study is feasible and has the potential to predict response to therapy, setting the stage for a larger study. OncoGenomics provides information about the effectiveness or chemosensitivity of specific anti-cancer drugs and targeted therapies like monoclonal antibodies and tyrosine kinase inhibitors on the cancer cells derived from a single patient. In order to confirm the information that the test generates, the cancer cells are exposed to the active substance of each drug, and we explore if the drug has the ability to destroy viable cancer cells. The test combines molecular and cellular approaches and are designed to identify specific anti-cancer drugs by incorporating two procedures: epigenetic analysis and viability assays to validate the data. We use these tests to confirm the viability of the cells that are exposed to the drugs that are being tested. This diagram shows the proportion of healthy cells in comparison with the primary population that respond to a cytotoxic drug. A cytotoxic drug is one that has the ability to destroy living cells. If a drug has over 80% cytotoxicity, the drug targets more than 80% of living cells in the sample. Therefore, it shows sensitivity. If between 35 and 80%, the drug targets 35 to 80% of living cells in the sample. Therefore, it shows moderate sensitivity. And if below 35%, the drug targeted less than 35% of living cells in the sample. Therefore, the substance is ineffective, and this is known as resistance. In this sample report, we see high sensitivity for cyclophosphamide at 82%, partial sensitivity for cisplatin, carboplatin, ifosfamide, oxaliplatin, melphalan, trophosphamide, and nedaplatin ranging from 40 to 75%, and resistance to the rest of the drugs tested. OncoGenomics reports details sensitivity to several chemotherapeutic agents, such as alkylating agents, epotholones, inhibitors of topoisomerase 1 and topoisomerase 2, nucleus spindle stabilizers such as taxanes and vinca alkaloids, and several monoclonal antibodies and small molecular weight molecules and tyrosine kinase inhibitors. OncoGenomics can tell us the risk for migration invasion, angiogenesis, proliferation, hormone receptors, cell cycle rates, and resistance phenotype markers. The assessment report also gives a summary of therapeutic options that may be suitable for the patient tested. For OncoGenomics, a CTC-based testing method, blood or tissue for CNS primary tumors may be used. 15 to 25 ml of peripheral whole blood is required, and turnaround time is 7 to 10 days. Next, let's talk about CambiSec, another diagnostic tool looking into the efficacy of agents used for treatment of cancer, which uses comprehensive genomic profiling. Comprehensive testing, usually from a small amount of tissue or blood, is done to look at all relevant biomarkers simultaneously. The frequency of molecular aberrations in various driver oncogenes are studied to identify current available drugs against these oncogenic proteins. It is advantageous in that instead of multiple tests, you can perform a single test that looks at all relevant biomarkers simultaneously, and it can save time and impact patient lives earlier. Comprehensive genomic profiling can identify actionable alterations. This was demonstrated in several studies which were done in patients with pediatric solid tumors and in patients with advanced cancers of multiple tumor types, demonstrating that 30 to 90% of patients may have an actionable genetic alteration after genomic profiling. Comprehensive genomic profiling has value in patient management such that it can increase the use of targeted therapy by more than double, increase patients' clinical trial eligibility by greater than 1,000-fold, reduce costs of non-targeted therapy by up to $6.6 million, and reduce adverse events by up to 1/3. Comprehensive genomic profiling results are classified according to the AMP, CAP, and ASCO variant classification, which is divided into 4 tiers as follows. Tier 1 are variants of strong clinical significance with Level A evidence and FDA-approved therapy or practice guidelines for the patient's tumor type, and Level B evidence with consensus in the field based on well-powered studies on the patient's tumor type. Tier 2 are variants of potential clinical significance with FDA-approved therapy or practice guidelines in other tumor types, evidence from multiple small published studies, or based on availability of investigational therapies. Tier 3 are variants of unknown clinical significance, and Tier 4 are benign or likely benign variants. An interpretation challenge would be how to maintain rapid turnaround while achieving the highest accuracy. So classification is quite accurate in that specificity is 99.99%, sensitivity is 93.77%, positive predictive value is 98.79%, and accuracy is 99.95%. Comparing draft versus signed out classification, true positive and true negative classifications remain the same after sign out, while false positive and false negative classifications changed after sign out. Comprehensive genomic profiling can rapidly identify variants that meet quality control parameters established during assay validation. Variants of a particular class or that meet criteria of interest include those clinically relevant variants, such as those with FDA label, NCCN guideline, clinical trial, or prior medical interpretation. The final list of reported variants with clinical impact are those with diagnostic, prognostic, and therapeutic relevance. RGCC Cambisec, which stands for Cancer Analysis, Mutational Burden, and Instability Sequencing, provides comprehensive next-generation sequencing analysis on both DNA and RNA to help predict a patient's response to immunotherapy and to detect variants. The purpose of the test is to help predict a patient's response to immunotherapy, chemotherapy, and other variants. It is used to help identify variants in more than 500 genes, detect fusions, and calculate tumor mutational burden and microsatellite instability. These mutations within the coding region are used as biomarkers of sensitivity to immunotherapy. Studying cells isolated from a blood sample or tissue sample, RGCC Cambisec incorporates biomarkers covering different types of cancer, requiring lower input, detects low-frequency mutations, and achieves reliable results with 99.9% specificity and more than 95% sensitivity. Cambisec gives information for more than 500 genes, which opens up therapeutic options of up to 47 drug labels, 38 guidelines, and more than 1,000 clinical trials that the patient tested may be eligible for. This is the full list of more than 500 genes that can be sequenced using Cambisec. Comprehensive genomic profiling is a method used by Cambisec from both blood and tissue biopsy samples. It is purely genomic, designed to identify key biomarkers in individual cancer cells to see which drugs can induce cancer cell death most efficiently. A patient's report will show genes with strong clinical significance and potential clinical significance, and other biomarkers such as tumor mutational burden and microsatellite instability. These are explained in more detail, giving extensive information about the genes classified as Tier 1 with strong clinical significance, Tier 2 with potential clinical significance, other biomarkers, and Tier 3 with variants of unknown significance. For Cambisec, which again is a comprehensive genomic profiling test, blood, tissue, or FFPE tissue may be used. At least 7 to 10 ml of peripheral whole blood, a minimum of 400 milligrams of fresh tissue, or a minimum of 100 milligrams or 1 block of FFPE is required, and the turnaround time is 2 to 4 weeks. Next, I want to focus on ChemoSNP, a diagnostic tool which can help assess PD and PK. In pharmacology, we are all taught about the most basic principles involved, which are pharmacodynamics and pharmacokinetics. Pharmacodynamics is formally defined as the concentration of drug at the sites of action related to the magnitude of the effects produced, or simply what the drug does to the body, while pharmacokinetics is formally defined as the dose, dosage form, frequency, and route of administration related to drug level time relationships in the body, or simply what the body does to the drug. So ChemoSNP tests for single nucleotide polymorphisms, which are variations in our DNA sequence that can affect if we develop cancer or if we respond to treatments with chemicals, drugs, and other agents. This test relies on pharmacogenomics. This is the science of inherited variations in genes, how these inherited variations dictate a patient's response to a drug, and the ways these variations can be used to predict whether a patient will have a good or bad response to a drug or no response at all. It studies single nucleotide polymorphisms in the genes that are involved in breaking down cytostatic or targeted drugs that are used in cancer therapy, and provides information about the ability of each individual to metabolize and activate each therapeutic agent in the most effective way. SNP analysis can predict drug activation and deactivation, show the relationship between the SNP and a clinical condition, predict the development of certain diseases like cardiovascular disease or diabetes, and shows the preferred response to specific treatments. For ChemoSNP, buccal swabs or peripheral whole blood may be used. 2 buccal swabs or 7 to 10 ml peripheral whole blood is required, and turnaround time is 10 to 12 days. There are also diagnostic tools available for following up and monitoring the patient, such as OncoCount, OncoTrace, or OncoTrail. For following up and monitoring the patient, OncoCount, OncoTrace, or OncoTrail can be recommended to detect the presence of circulating tumor cells, to measure their concentration in the blood, and immunophenotype, which may help identify their origin and provide data on specific types of malignancies, such as breast, prostate, lung, GI, colon, sarcoma, and melanoma. For these follow-up studies, 7 to 10 ml of peripheral whole blood is required, and turnaround time is 7 to 10 days. To summarize, for patients presenting with cancer, OncoGenomics using flow cytometry and circulating tumor cells, or CAMBISEC using comprehensive genomic profiling of DNA and RNA, can be recommended to identify active substances and drugs that can be used against the disease. ChemoSNP can be recommended to identify whether the patient is able to normally metabolize each agent and receive the biological benefit from it. For following up and monitoring the patient, OncoCount, OncoTrace, or OncoTrail can be recommended to detect the presence of circulating tumor cells, to measure their concentration in the blood, and immunophenotype for specific types of malignancies such as breast and prostate cancer. And these follow-up tools can be done every trimester for the first year and then every half year. Thank you.
Thank you, Dr. Ishka. For our attendees, please use the Q&A panel found on your dashboard if you have any questions, and we'll do our best to accommodate all those questions. For the first question that we got, Dr. Ishka, economics play a very big role, especially this pandemic. When do you recommend using epigenetics analysis and viability assays for cancer drugs efficacy? Since this is not part of the guidelines, do you recommend it to all cancer patients? When do you usually recommend such tests?
Hi, Dr. Agnes. Thank you for inviting me today. So, regarding economics, this is a big thing here, especially in the Philippines, being not a first world country. No? So, most patients would do out of pocket payments for treatment.
Yeah.
So it's a very important issue in terms of cost. No? So most of our next generation sequencing tests looking into these mutations cost a lot of money, usually around maybe 2,000 to 4,000 US dollars and even more to take a look at these. No? So it's very important that we look at this, and ideally it's important to do the testing at diagnosis, especially for metastatic cancers, so that it can help guide the oncologist or the rest of the doctors in the patient's team treating the patient. No? It's very important to do this to guide their treatment. There are a lot of available targeted therapies these days, and this is basically what CAMBISEC next generation sequencing will be able to tell us. So it's important to do this at diagnosis of a metastatic cancer if possible. Most of the time in the Philippines, no, most oncologists will resort to this during later lines of treatment because patients will not be able to afford it immediately, and they usually try to exhaust all other treatments before doing the testing. But ideally, it's good to do this on diagnosis and on every progression of the disease.
Okay. The use of NGS in cancer management is really gaining traction in countries like us in the Philippines. What is your take when people comment about the price of the NGS test, especially when they're comparing it to the benefit of the test?
Okay. Well, for the benefit of the test, we all know this because doing the next generation sequencing really helps to guide in terms of treatment decisions, looking into what targeted therapies we can specifically give the patients. So, of course, looking into the benefit for the test versus the cost, definitely the benefit is there because it really targets whatever is seen in the genes or the DNA of the patient. The problem though is cost again because mostly here in the Philippines, everything is out of pocket. I would suppose in other healthcare systems in like first world countries, more developed countries, it wouldn't be a problem. And I'm hoping that in the future, maybe we'll be able to use these next generation sequencing tests more frequently for our patients in the Philippines.
Thank you, Dr. Ishka. Time flies if we are enjoying such discussion, especially this very good lecture. Unfortunately, that is all the time that we have. We will forward all your questions to Dr. Ishka. If you have additional questions or inquiries, we can get Dr. Ishka's details from AOS Secretariat. To close this session, can we ask for one last statement, Dr. Ishka? What do you want to impart to our audience before we end our session?
I want to remind our oncologists, whenever we plan out for treatment for patients with metastatic disease, we can consider using next generation sequencing on diagnosis and on progression of the disease to be able to help us find targeted treatments to be able to also offer better prognosis and treatments for our patients.
That was a great ending statement, Dr. Ishka. Again, I would like to thank our speaker, Dr. Frances Victoria Ishka, for this. Thank you, dear audience, for your participation. Enjoy the rest of the lectures today.
Thank you.
Thank you.